Good morning and welcome. Thank you for joining us today for the webinar on assessing functional living skills. Just to begin with the disclosure, both Dr. Roden and myself are employed by Pearson, and we're going to talk about, Gail specifically is going to talk toward the end about some of the instruments that Pearson publishes that are helpful in looking at functional living. So just to be clear about all that. So these are our learning outcomes for today. We're going to talk about what functional living skills are and the importance of assessing functional living skills in adults. And then we're going to, Gail's going to talk to you about some of the instruments that are used in assessing functional living skills in those evaluations and the areas or domains that they are useful for. So just to begin, I want you to think about your morning routine and that of many people. You wake up, you sit up, you swing your feet over the edge of the bed, you stand up and walk maybe towards the bathroom, take care of toileting, maybe shower, brush your teeth, many other grooming activities then to prepare yourselves for the day. When it comes time to think about food, you may either plan a meal, take out the necessary ingredients and prepare the meal and then eat, or you may even plan a full menu and have to shop for the foods that you want to eat and then prepare the meal. You sit down to eat and feed yourself. After the meal, you may clean up the kitchen, wash the dishes. All of these kinds of activities and many others are referred to as activities of daily living. These are the basic self-care tasks that an individual does on a day-to-day basis, and they're fundamental in caring for oneself and in maintaining independence. An individual's ability or inability to perform these activities of daily living is often used by healthcare professionals as a way of measuring an individual's functional status, especially that of older adults and those with disabilities. So the assessment of overall functional abilities in older adults really refers to a pretty comprehensive evaluation that often is to determine that level of independence that older adults have when performing these activities of daily living. Functional impairments and then cognitive and affective problems are particularly prevalent among older patients, as we'll talk about. So the assessment, these types of assessments of functional abilities often take place in settings where decisions about a person's ability to live independently or the determination of what level or kind of assistance or supervision a person may need are being made. They're often part of a psychological and medical evaluation in various settings. And although I mentioned ADLs earlier, they're really divided into two types based on level of complexity. So basic or personal ADLs and instrumental ADLs or IADLs. In a narrow sense, functional living really can be defined as the ability to function in the arena of everyday living. So first, let's look at these personal ADLs, basic ADLs. Sometimes those are referred to as BADLs. Again, these are self-care activities. They're routinely performed, and they include, but are not limited to, functional mobility, which includes the ability to walk and or transfer in and out of a chair or bed, or propel oneself if you're in a wheelchair, so mobility. Essentially there, it's the ability to move from one place to another as the person goes about, a daily routine. And then personal hygiene, oral care, grooming, including skin and hair care, showering, bathing, toileting, which includes getting on and off the toilet and cleaning oneself, dressing, which includes both selecting the appropriate attire and then putting it on, self-feeding. One way to look at these basic ADLs, again, is to think about them as the activities a person does throughout the day. When you get up in the morning preparing to leave the house, and those that you do regularly, day in and day out. And as a person ages, these ADLs slowly become more difficult to accomplish independently, and they gradually take more time to complete. Some health issues, such as stroke or accidents, things like a fall, those also can affect a person's ability to accomplish ADLs, sometimes pretty dramatically. So these are the essential elements of self-care. These functional skills are mastered early in life, and they're relatively more preserved in light of declining cognitive functioning when compared to higher-level tasks. Physical functioning is often a significant driver of this basic ADL ability. And, of course, the inability to independently perform even one of these activities may indicate a need for some level of supportive services. We think of this ability to independently carry out these basic ADLs, particularly the ability to engage in personal care, as a key part of functional independence. ADL impairment is a really strong predictor of hospital outcomes like functional decline, length of stay, institutionalization, and death. It's a stronger predictor than the actual admitting diagnosis or the diagnosis-related group or any other physiologic indices of illness burden. ADL impairment is also a risk factor for nursing home placement, emergency room visits, and even death among community-dwelling adults, as you can imagine. But ADLs alone don't measure the full range of activities necessary for independent living in the community. IADLs, or instrumental activities of daily living, while not essential for basic functioning, these are the ones that enable a person to live independently within a community, because you can have help with some of the other activities of daily living, and it's often impairment in these IADLs that drive residential change. IADLs assess the person's ability to keep an independent household. They're generally more complex than basic ADLs. They're made up of activities that include, but aren't limited to, housekeeping, laundry, other home care chores, money management, meal preparation, moving or changing residences, shopping for groceries and other necessities, medication and health management, using the telephone or computer, transportation or arranging for transportation, pet care, and often care of others. So as I mentioned, IADLs are associated with independent living in the community, and they provide a basis for considering the type of services necessary in maintaining independence as well. An evaluation of IADL performance often will provide us an enhanced understanding of the impact of cognitive impairment on daily functioning. The literature suggests that there's a relationship between IADL function and behavior and ability as well. So IADL performance is sensitive to early cognitive decline, and IADL impairment can often present in mild cognitive impairment and early dementia, and often a breakdown in IADLs may be the first sign of dementia. Comparatively, basic ADL declines are often not present until later stages of dementia. And now the DSM-5 diagnostic criteria for major neurocognitive disorder actually specifies that functional impairment with IADLs must be present for the diagnosis. And IADL dysfunction predicts dementia, institutionalization, and death as well. So looking at who needs assessment, functional ability and related factors really weigh pretty heavily in decisions that older adults make about their own employment, their health care, relationships, leisure activities, and even, or maybe most specifically, their living environment. Function itself is multifactorial, so when we assess these areas, we assess multiple areas, often using more than one test, as we'll talk more about later. This kind of assessment then enables the planning of therapeutic interventions, social care if necessary, clinical support. It also supports clinical reasoning, again, in detecting early signs of dementia. So together, ADLs and IADLs make up those skills a person generally needs to successfully and safely live independently. So that a person's ability or inability to perform the ADLs and IADLs is used to gauge their need for care and various types of interventions or therapies, including frequently occupational or physical therapy. And as you can see on the slide, the most obvious candidate for an assessment is one who is known to have or suspected to have cognitive impairment or decline. So cognitive impairment and ADL status are correlated, but they're separate dimensions of functioning. Not all persons with substantial cognitive impairment have ADL dysfunctions. So a functional assessment really is a comprehensive evaluation of the physical and cognitive abilities that are required to maintain that independence. Physicians, geriatric social workers, rehab specialists, OT, PT, psychologists, others involved that are working with seniors often are those called on to evaluate a person's ability to perform ADLs and IADLs as part of a functional assessment. And that typically includes the ability to perform those activities of daily living, the ADLs, bathing, eating, dressing, etc., and the independent activities of daily living, so managing finances, preparing meals, managing their health. All of those, again, really require a combination of cognitive and behavioral skills. So the assessment then would look at cognitive and behavioral skills, and then other components of the assessment would evaluate objective measures of physical health and psychological and social functioning. So difficulty with function with activities of daily living and IADLs increases with age, impacting the ability to remain independent, as you can see here. Just as the age increases in both ADLs and IADLs, the percentage of people with difficulty increases pretty consistently. If you're noticing signs in an older person, such as some of these, it may be time to consult a physician and get an understanding of what may be happening. And I say physician because often these, there is often a medical component to this as well, so that needs to be a part of this kind of evaluation. Some of these issues are generally related to some normal physical declines and frailty that are associated with advanced age, but some are also signs of dementia or some other diseases. And in some cases, early intervention in certain diseases can halt or even slow down the progression of worsening symptoms. So that's the beginning point is often a medical workup alongside the rest of the workup. Functional impairment is defined as difficulty performing or requiring the assistance of another person to perform one or more of these activities of daily living, bathing, dressing, toileting, transfers, grooming, and feeding. And again, those seem really basic and are referred to as basic ADLs, but they are comprised of different types of skills that really require things like sequencing of action, conceptual knowledge, and manipulation that are all needed to achieve the intended goal, even of those really basic activities. ADL assessment is often requested in the middle or later signs of dementia or stages of dementia, as I mentioned, but it often can occur during the course of recovery for an acute event like a stroke or TBI. Referral for this kind of evaluation may often include a question of cognitive, emotional, or behavioral factors that can be interfering with functioning in these basic skills and how these barriers may be overcome to enhance independence for a person. And then, of course, often functional assessment is a part of a broader capacity evaluation for independent living or guardianship. But changes in the healthcare marketplace have really resulted in a lot of younger people, specifically those under age 65. Those under age 65 are about 12 to 14% of nursing home residents today, and so that's the fastest growing segment of the institutional long-term care population, and many of those have developmental disabilities or have had TBIs. There was a 2010 study that noted that over 40% of those who need long-term care are under 65 years of age, including children and adolescents with intellectual disability and developmental disability, young adults with congenital degenerative conditions or acquired brain injury, and those with HIV or AIDS. So that's a pretty good-sized population, and that includes residential care, not just nursing home facilities. So in general, individuals with any of these types of symptoms or signs or illnesses can benefit from a functional assessment. Functional dependence in community-dwelling older adults is pretty common, and it's associated with lower quality of life and increased health care costs and, as I mentioned earlier, mortality. Normal changes due to aging and acute illness and worsening chronic illness and hospitalization can often contribute to a decline in the ability to perform those tasks that we consider necessary to live independently in the community. And it's this information from a functional assessment that can help us obtain the objective data to assist with targeting individualized rehab needs or to plan for specific in-home care services, things like meal preparation or nursing or personal care, homemaker services, sometimes financial and medication management, or even continuous supervision. That functional assessment really helps the clinician to focus on the person's baseline capabilities at the time of the initial eval, and then can facilitate, recognition of changes that may signify a need for either additional resources or for a medical workup. So, progress monitoring in a sense, or decline. The need for functional support often increases as people age due to functional limitations associated with various physical ailments that often accompany aging. The development of a medical illness that results in changes in the person's ability to care for him or herself often puts a person in the hospital and then rehab and then either back to the house with changing levels of care or sometimes into a skilled nursing facility. But even a gradual decline of physical abilities can eventually limit a person from being able to perform those activities of daily living, as well as the IADLs. And the same is true for something, for the development of things like just memory problems that can lead a person to forget about the soup on the stove or to take their morning medication or forget how to get to the grocery store or the post office and back. So the development or the exacerbation of mental health problems related to even, a thought disorder or a mood disorder can often affect a person's ability to live independently. There's a lot of reasons that somebody becomes homeless, for example, including mental health problems, substance abuse issues, and cognitive deficits. In general, when a person's ability to care for himself or herself comes into question, an evaluation to determine independent living capacity should be considered. So kind of in summary, we assess ADLs and IADLs as part of assessing an older person's function. Problems with ADLs and IADLs usually reflect problems with physical health and or cognitive health, and so identifying functional difficulties can help us with the diagnosis and help manage important health problems. But most importantly, we're trying to identify functional difficulties because we want to make sure older adults are getting the help and support that they need, to compensate for or, if possible, to overcome these difficulties. And we want to help family caregivers who might be struggling to assist a relative who needs help. The ability to perform ADLs and IADLs is dependent on things like cognitive, so reasoning and planning abilities, motor abilities, balance and dexterity, and perceptual abilities, including sensory abilities. And there's a really important distinction of an individual's ability to complete a task, so having the physical ability and even the cognitive ability, versus the ability to recognize that the task needs to be done without prompting, which of course is strictly cognitive ability. In a lot of settings, ADLs are directly assessed by occupational and physical and speech therapists or by nurses or other members of a medical team that, to help guide day-to-day care and as part of discharge planning. Referral for an ADL eval may frequently include a question of cognitive, emotional, or behavioral factors that can interfere with function in those very basic skills. And then, a look can be given to how those barriers might be overcome to enhance independence. There's an increasing emphasis on the impact of treatments or on outcome measures, or the impact of treatments on quality of life and functional independence. And so assessing an individual's daily functioning, especially in residential settings, is imperative to developing effective treatment plans in all domains of medical and mental health. But with an aging population, the assessment of the ability to complete tasks that are required to live and function independently really is going to continue to be an important area of evaluation. So it's important to evaluate, including by direct observation when possible, a person's functional abilities. We want to determine the patient's ability, again, to live alone safely, their ability to be compliant with health care recommendations, and to complete the IADLs. Clinicians who perform these types of evals are really strongly encouraged to address a wide range of adaptive behaviors relevant to overall daily functioning, conducting functional assessments of self-care skills and everyday living skills. These assessments often augment other psychological assessment or are part of that type of broad assessment. More specific functional skills assessment, like decision-making specifically, that is often an important element of a capacity assessment, which is frequently done, again, during a guardianship. But it allows us to look at whether a particular intervention has been helpful. As I mentioned, it allows for monitoring of changes from week to week or time to time, whether there's progress or decline. Looking at the component skills that are evaluated, IADL and ADL functioning really appears to be composed of different underlying performance factors. Many studies have been conducted on the relationship between attention, memory, executive functioning, visual spatial functioning, and ADLs. Attention has really been found to be an important predictor of overall ADL scores in patients with dementia. Attention and immediate memory have been correlated with poor performance on physical self-maintenance. Attention was associated with bathing impairment, suggesting that attentional impairments that emerged later in the dementing process may be driving impairment in basic ADLs. And then other studies have demonstrated a relationship between memory and ADL functioning. In one study, changes in memory scores significantly predicted declines in basic ADLs. In another, both immediate and delayed memory predicted deficits in dressing ability. Studies evaluating the relationship between ADLs and executive functioning are even more convincing. Difficulties in executive functioning have been shown to predict both ADL and IADL impairment in women and men with mild Alzheimer's disease. And compared to women without cognitive impairment, those with executive functioning impairment had significantly worse ADL functioning over the course of 6 years. And then visual spatial skills have also been found to play a role in basic ADL functioning. So there's a strong relationship between these self-care measures and some of the cognitive domains that we look at. Assessing apraxia can be particularly important in cases of recent stroke. Let's see, what else? I don't want to miss anything important about all of those areas, but those all are areas that are important to consider. And then more comprehensively, there's been studies that have shown that the accurate and reliable execution of IADLs really draws on the integrity of a wide range of cognitive processes. Disabilities in older adults are often due to age-related cognitive and physical changes, so changes in the sensory system or the cardiovascular system, musculoskeletal system, the direct and indirects of chronic diseases. So clinicians really have to be proficient in the functional assessment of strengths and limitations in ADLs and IADLs in the context of the environmental demands of the patient and the supports that they have, in their environment, both if they're in the hospital or in rehab, and then if they're seeking to return to home. To make really ecologically valid recommendations in those areas, the clinician needs to integrate the assessment results with things like clinical interview information gathered from both the older adult and collateral sources, direct observation of the older adult's functional performance, along with other considerations like, again, the immediate physical environment, the available social supports, even local legal standards if necessary, the patient's sensory and language impairments, if any. Several approaches can be taken to assess functional abilities, and those range from questionnaires to performance-based evaluation, but they need to include all of these areas depending on, of course, the particular patient situation. Assessment tools provide objective measures of physical health, activities of daily living, IADLs, and psychological and social functioning. Neuropsych tests are often better at predicting IADL functioning compared to basic ADL functioning, but typically neuropsych assessments alone are not really in and of themselves sufficient to fully assess that basic functional ability. So an interdisciplinary approach, including the use of specific ADL measures, is recommended. So clinicians conducting these really should do so when possible as part of a team of professionals, because they use various measures to determine cognitive abilities and decision-making abilities and physical functional abilities, looking at whether or not any of the factors are reversible. Again, in some cases, these are done in the context of determining whether an individual may need a guardian of person or in a more narrow band guardianship maybe. In other cases, these evaluations may remain more in the clinical realm, focusing on helping to determine those, the appropriate discharge location that matches the person's needs. But the evaluations are often among the most difficult because they concern such a fundamental value, independence, in a person, and because that we do hold that so close to our chest. And then, because the range of skills and abilities are potentially relevant is also such a vast range. So just a little more about executive functioning before we move on. When you think about how to best measure IADLs, I mentioned some of the studies, and you see some here that have shown relationships between measures of executive functioning and decline in IADLs. But often patients with executive disorders can perform relatively well on traditional neuropsych tests of frontal lobe function, yet show marked impairment in controlling and monitoring their behavior in real-life situations. And the types of real-life deficits shown by patients with impairment in executive functioning can include tasks like you see on the slide, and things like the inability to plan and prepare meals, and the inability to plan and carry out a sequence of errands, like you need when you're shopping. Those IADLs that rely on higher cortical abilities are defined under executive functioning, and these are the ones, remember, that are really considered necessary for independent living. So medications, telephone, preparing hot meals, managing finances, etc. Impairments in these areas usually have really severe consequences on, if nothing more than on a broad range of areas, but mostly on that person's ability to live alone. So successful performance of IADLs kind of confers the ability to age independently in the community. But although there's an established relationship between cognition and IADLs, studies that have examined the relationship between executive functioning and IADLs really show that executive functioning may be a better predictor of IADL impairment in older adults than other global cognitive measures. And it's important to consider also those ADL skills, not just IADLs, because they have to be evaluated in the context. The ADLs also need to be evaluated in the context of executive functioning, because you have to be able to recognize the need to perform the activity, to initiate at the appropriate time and frequency. You have to be able to organize time, to evaluate effectiveness on completion, and to manage several interrelated tasks. So they both need to be evaluated in the context of executive functioning. So older adults have to be able to successfully practice self-care and self-protective functions in order to remain in an independent setting. And so those impairments in executive functioning that affect ADLs and IADLs and in maintaining living environment and basic medical self-management and maintaining financial affairs really affect that independent living ability. And then things like the capacity to consent and driving and timely symptom recognition and appropriate medical decision-making, as I mentioned, those are all things that are necessary for independent living. So independent living really doesn't require that an individual be cognitively intact, but if deficits are present, it requires a determination as to what extent they affect the person's ability to live alone and what, if any, adjustments have to be considered to the individual's environment to enhance their cognitive strengths. Okay, so looking at assessing, is cognitive assessment sufficient when conducting the type of eval? For most older adults, normative age-associated changes in cognition are mild and don't significantly interfere with daily functioning, but an appreciable minority of older adults suffers impaired cognition that will adversely impact their functional abilities. So cognitive assessment really probably is not sufficient. Older adults that live with dementia often evidence coexistent psychological symptoms, as some of you probably know. Depression and anxiety and paranoia, behavioral disturbances sometimes can coexist with dementia. And as functional ability declines, the environment becomes increasingly important in maximizing the older adult's functioning and their ability to maintain their quality of life. So again, this really requires a more specialized assessment of looking not just at cognitive function, but also at ADLs. And there's some specific instruments that have been created for evaluating ADLs, like the CATS, K-A-T-Z, that are used to assess the functional ability in those areas of bathing, dressing, toileting, transferring continence, and feeding, pretty specific physical tasks. There's another one, a timed get up and go, measuring the ability to walk, that many of you may know about. Gail's going to talk some more about additional instruments in a bit, mostly ones that focus on IADLs and the cognitive domains that impact the ability to carry on, IADLs and ADLs. But that slide, the previous slide, sorry, let me go back for a second, that really could have been also titled, Is ADL IADL assessment sufficient, as it's really important that those areas not be the only ones involved in a functional living assessment. IADL assessment is also insufficient to evaluate the capacity to live independently because it really is more of a categorization of important activities, and it doesn't consider the cognitive and judgment skills related to these key judgmental abilities, such as the ability to handle emergencies and compensate for deficits. The judgmental factors really are the ability to identify a problem, generate alternative solutions, make the decision, implement the solution, verify the solution, and things like that. So we really, want to also consider those cognitive factors and the ADLs and IADLs. There's several types of approaches that have been used to quantify the level of independence when looking at a functional living eval. They may be measured by self-report, by proxy or caregiver or informant report, and direct observation, and then also by the use of standardized or norm-referenced measures. And these are all useful when seeking to obtain a general sense of the level of assistance that's needed in the type of setting. Performance-based measures can provide objective data about that ADL functioning, but they generally require more training to administer as compared with self or informant reports, and usually are ADL-specific assessments usually are performed by OT/PT or someone in a medical setting, often also a nurse. Self-report measures are convenient. They're frequently used when direct observation isn't possible or when individuals are relatively cognitively intact, but they may be less valid when individuals have poor insight into their functional impairments. Informant-based ratings are commonly completed by caregivers who know the patient well, but they may also be biased by their own burden in caring for the individual or even by underestimating a patient's true functioning. So they're useful to include in an evaluation of ADLs, caregiver or informant report, but they may not be entirely free of bias, and some patients may not have caregivers, of course. Direct observation should always be included when possible, but it also should include some form of caregiver or collateral report. For an individual that's hospitalized, you may want feedback from nurses who work with the patient daily. They can provide information about how the person is functioning within the hospital, if they're forgetting to use a walker, if they're impulsively getting out of bed and falling, wandering, things like that. Feedback from neighbors or family at home can help. Collateral informants can corroborate information provided by the self-report, and also by direct observation. So the direct observation information you get really is dependent on, where you're observing. If you're observing a spot of the moment event, or if you're observing kind of more generally, and that's where informant reports can be helpful as well. Performance-based functional measures have been used to circumvent some of those problems with self-report and caregiver report instruments. They require that an individual being assessed perform a set of functional tasks so that the ability to execute the tasks can be ascertained. And those may include things like assessment of gait, balance, and lifting in the physical realm, and then cognition, of course. There's a number of instruments that are available for integrated assessment of physical and mental function, looking at the evaluation of ADLs and IADLs. But you can see some of the advantages and disadvantages of performance-based measures here. A combination of self-report and performance-based measures of ADLs and IADL performance and any available informant information, that really may be the best way to fully capture the picture of disability for a given individual. Of course, together, the objective performance measure and the individual's subjective appraisal of how they think they're doing or how they've done on a task. That's sometimes reflected in self-report or interview, alongside that informant information, really can be useful in contextualizing their functional ability. So looking quickly at some of the considerations when you're thinking about instruments, it's important as clinicians that we develop knowledge and skill with respect to the standardized measures that we have to select from, and this involves understanding psychometric theory and test standardization and the importance of using assessment instruments that have been shown to be reliable and valid with the population with whom we're using them. This really includes an understanding of the importance of appropriate content and age norms. When there's not an instrument for measuring a particular assessment domain that's been developed, for example, for older adults specifically, we as clinicians are encouraged to rely upon instrument assessments that are developed with young adults only when there's also normative data available for which there's validity and reliability evidence to support their use with older adults. So we want to consider the age range for which the test was intended and normed. Does it allow for out-of-age range use? We want to look at the normative data. Were clinical samples used for validation? What is the research basis for the tool? On what population was it developed? Of course, we're encouraged to consider methods of assessment appropriate for the population as well. But in addition to using standardized measures shown to be reliable and valid with this population, it's also important to consider the impact of sensory impairments, living contexts, and cultural backgrounds of older adults during the assessment. We want to consider the potential confounds that may affect performance, things like sensory deficits and disability and language barriers or lack of access to resources or formal education, health literacy. We want to select culturally appropriate assessment instruments as available. We need to consider the older adult's ethnic, racial, and cultural background, but also other factors such as, again, their degree of health literacy, their prior experience with mental and behavioral health providers. We want to consider what the purpose of the evaluation is. The patient needs to be made aware of the purpose of the evaluation, and that can be a difficult conversation to have when the evaluation might determine whether a person is able to return safely to independent living or will be moving to more restrictive living environment. It's something the clinician needs to be aware of ahead of time and be prepared to have that conversation with an older adult or with the adult. So looking really quickly at some of the factors involved in assessing older adults, I'm not going to spend time here, but just to remind you that that is the most rapidly growing population in the United States. So clearly we're doing more and more evaluations with that population. And a thorough evaluation with an older person is really preferably an interdisciplinary one, focusing on strengths and weaknesses, determining how problems are interrelated, and taking account of the multiple possibility of contributing factors. Comorbid conditions such as acute illness or alteration in nutrition or hydration, chronic illness, delirium, dementia, economics, environment, et cetera, all might have negative impact on the functional status of an older adult. And so it's super important to be aware of those and to ensure that those areas are evaluated when there is a potential for an impact on the functional ability. And as I mentioned earlier, clinical approaches to assessing such a broad capacity really utilize a wide array of traditional cognitive measures as well as behavioral and psychiatric and functional measures incorporating subjective, what an adult reports he or she can do, and objective, so performance-based or direct observation, especially of functional abilities, is recommended because they can really significantly vary from each other. So you want maybe a review of medical records, clinical interviews, standardized assessment measures, including performance-based measures, observation and data collection of in vivo decision-making activities when possible, measures of mood, a review of medical pharmacological evaluation to determine what cognitive factors, if possible, if present, might be reversible. Maybe an assessment of substance use and misuse of prescription medications, et cetera. This is not an exhaustive list, but it's a list of potential areas that might be incorporated into an evaluation of an older person's ability to live independently, to retain their functional ability. Just a few other considerations. Sometimes an in-home assessment is what's necessary, but it also allows the clinician to evaluate aspects of home safety. And these are just some of the things that should be evaluated in an in-home evaluation. I'm going to hand this over to Dr. Roden to talk about some of the measures. Thank you.
Thanks, Anne-Marie. Good morning, everyone. Thanks for joining us. I'm going to spend the remainder of our time talking about measures that you can use to actually conduct functional living assessments. And we've divided these up into 3 tiers. So tier 1, the first 3 measures I'm going to talk about, are not specifically designed for functional living skills assessments, but they're a good place to start to quickly get a good feel for the general level of cognitive functioning of a client and to identify any specific areas of weakness. So we call these, again, Tier 1 measures, as they function as broad-based screening tools. And the three I'm going to talk to you about are the Brief Cognitive Status Exam, the CLQT+, and the RBANS, which is now the RBANS update. So let's talk first a little bit about the BCSE. This is, in a time-limited visit, many clinicians are going to begin with a screening instrument like the BCSE, which is used to assess cognitive abilities quickly and reliably, including in patients with dementia, mild intellectual disabilities, TBI, or suspected Alzheimer's disease. This is a very brief, reliable, standalone version of the optional BCSE that you may have used in the WIMS-4. It provides a short screening for cognitive problems and can identify significant impairment even in low-functioning individuals. Remember, it's not diagnostic of a specific clinical disorder, but it does give you an indicator of current cognitive status. For example, is it average, low average, whatever. It's weighted toward measures of processing speed and mental control. Those are issues common in individuals with significant cognitive difficulties. So low scores likely point to difficulties in those areas of functioning. The test will classify performance into 5 levels of functioning, with low and very low scores suggestive of possible clinical issues. Here are the cognitive domains that are covered by the BCSE. Notice that clock drawing and inhibitory control tasks are included, as these are particularly sensitive to age-related cognitive decline. And in case you're not familiar with the term incidental recall, it just refers to the client's ability to remember information when you haven't explicitly told them to remember it or tipped them off that they'll be asked about it later. And you'll see more about this in a moment when we talk about the TFLS. The second of these Tier 1 measures I wanted to mention is the CLQT+. This was developed by Dr. Nancy Helm Estabrooks, who's a leading neurobehavioral researcher and author. It's a criterion reference measure. It lets you quickly assess strengths and weaknesses in 5 cognitive domains, which I'll show you in just a moment. It's an effective tool for both English and Spanish-speaking adults who have known or suspected neurological impairment as a result of stroke, traumatic brain injury, or dementia. The plus that you see in CLQT plus indicates that this new version has added an important element, which is an optional new administration path for people with aphasia. For example, clients who've suffered a stroke that severely limited their verbal communication. And here are the cognitive domains that are used with a traditional, that is, with a non-aphasic patient. The only reason that clock drawing is in parentheses here is that it does not contribute to the composite severity rating that you also get out of this measure, but the other 4 domains do contribute to that overall score. And in each of these areas and for the overall score, you'll get a severity rating that ranges from within normal limits down to severe impairment. Again, here are the tasks that make up those domains. Again, you'll see clock drawing. You're going to see that over and over again, along with some of the things you might more readily expect, like memory measures. The third screening task I want to talk about is the RBANS update. This is one of my favorite screening instruments because it's quick, it's easy to administer, it's normed for a wide age range, and it has 4 parallel forms. So you can repeat testing and monitor for change over time, whether that's improvement that comes about because of supports or interventions, or decline if you're tracking a dementia or a deteriorating condition. Also, if you happen to be a Q Interactive user, RBANS Update is available on that platform, so that's an important thing to know. So here are the domains that are covered by the RBANS Update. And next, I want to take you into what we're calling Tier 2. These are the actual functional living skills measures. These are the ones that assess those IADLs that Dr. Kimball talked about. Pearson has two excellent options in this area. The TFLS, which is short for Texas Functional Living Scale. This one's a shorter instrument, more along the lines of a screener, but it does cover all the essential areas that you'll need to assess. The other option that we have has more items and takes longer to administer. This is the ILS, the Independent Living Scale. So let's look first at the TFLS. It's a brief 24-item assessment of skills related to living independently, things like paying a bill, remembering instructions over a brief period of time, or performing basic money transactions. The items on the TFLS were selected to make it particularly sensitive to identifying early cognitive decline. Because it's brief but powerful, you can both administer and score it in less than half an hour. Many of the items on the test are scored by assigning from among a range of possible points, and this allows for the test to account for varying levels of functioning that might be observed in clinical populations. The scores you'll get include cumulative percentages for each of 4 subscales, plus an overall T-score that you can use to help determine the client's ability to function independently. Here are the 4 subscales of the TFLS: the time subscale, money and calculation, communication, and memory. The time subscale takes a look at how well individuals can use a calendar, how well they can do clock drawing, and determine time by reading a clock. So here's the calendar items are things like this. The examiner asks the questions that are like these, while the client looks at a calendar for the current year. Calendar items are scored 0 or 1, depending on whether they're incorrect or correctly answered. Time items. These use a response form, and they're used to test whether the client can read the time from an analog clock face, as well as whether they can correctly position the clock hands to show a time that you give them. Scores on these range from 0 to 3 points, and the scoring criteria are on your TFLS record form. Next, we look at the money and calculation subscale. It begins with a clock-based item as well, and then it moves to items that require the client to work with actual coins and paper bills. The first item checks to see whether the client can calculate how long it will take between the time shown and a later time specified by the examiner. You score 0, 1, or 2 based on criteria that are in the record form. Now, at this point in the TFLS, the examiner provides a cue for a memory task that's going to be evaluated and scored later. After giving the instructions that you see here, the examiner starts the timer and continues administering TFLS items until the alarm sounds because time has expired. And we'll see below what happens then. So they say, when this timer goes off, take 3 pieces of candy from this plastic bottle, and you leave the bottle in view on the table. So meanwhile, you continue administering items in the money and calculation domain. The first items are relatively easy. They ask the client to identify the amount of money represented by various number of coins on the table. Then you give them a Ziploc bag with coins in it and ask them to take out coins that add up to a given amount of money. These are all items that are scored 0 or 1. You either get them correct or not. The next 3 money and calculation items use both coins and bills that are placed on the table, and they involve questions like the one you see here. Next, we move to the communication domain, and this subscale looks at really important IADLs, which you might not think of as related to communication, but the ability to complete them successfully relies heavily on reading and writing ability, as well as oral language and comprehension. For the first item, the examiner provides the client with a water bill and a blank check and asks them to complete the check in order to correctly pay the bill. There are 5 components that are scored on the check. and each one is given a score of 0 or 1. Next, the client is given an envelope and asked to address it to send in the payment for this bill. And scoring, again, involves assigning points based on the completeness and correctness of both the mailing address and return address. Next come 5 communication items that test the client's ability to use the telephone as well as a phone book. The phone book contains both white pages and yellow pages, and it's included with the TFLS kit. So first, the client has to locate a specific person in the phone book and pretend to dial their number on the phone. Then they're asked to locate a drugstore or a pharmacy and pretend to dial that number. Finally, they're asked to specify what number should be called in an emergency. Still within the communication domain, the client's asked to show or tell the examiner how to make a peanut butter and jelly sandwich. They get points both for correctly giving the steps and for sequencing them correctly. There we go. So the final communication item on the TFLS, you'll show the client both a recipe and a large picture of a microwave oven. Then you ask them to pretend to set the microwave so the food will cook correctly. Points are assigned based on correctly carrying out the required steps, excuse me, as well as whether the steps are sequenced properly. Finally, we move to the TFLS memory subscale, and the first item is administered when that timer goes off to indicate that 5 minutes has passed since the cue was given. And now we take a look to see whether the client, without prompting, goes and opens and takes 3 candies out of the jar, or whether they need a verbal prompt or a pointing prompt, or whether they don't perform the action at all. And based on which of those happens, we assign between 0 and 3 points. Then the final 2 memory items assess incidental learning, which, as I mentioned, is the ability to recall information that they've been exposed to but haven't been instructed to remember the way they were told to remember to take the candies out of the bottle. So in this case, we asked them to remember who was the payee on the check that they wrote out and what was the amount they wrote on the check. So that's the content of the TFLS. Now I'm just going to talk briefly about the ILS. It's a longer scale, considerably longer. It has 7 screening items followed by 70 items. Most of them are scored 0, 1, or 2. A few of them are just scored 0 or 2 for correct or incorrect. And all the detailed scoring criteria are in the ILS manual. So this is an individually administered assessment designed to assess the degree to which adults are capable of caring for themselves and their property. The norms were created using a standardization sample that included adults ages 65 and above who were living independently, semi-independently, or dependently. And what you will get are standard scores for 5 subscales, a full scale standard score reflecting overall performance, and then separate factor scores for problem solving and performance. And this is a really important component of the ILS. So these additional factor scores help you interpret a client's performance in those 5 functional domains. Performance information factor, this one, refers to the ability to perform simple tasks while problem solving involves reasoning. So most of the tasks that make up the performance information factor are things that can be taught. For example, things like performing simple math calculations or using a phone. In contrast, the problem-solving factor concerns the client's ability to apply this knowledge. So for example, a client may have the factual knowledge of what number they should dial in case of an emergency. That would fall under the performance information factor. But they may not comprehend that they should use it to call for a doctor if they experience chest pain. That would be problem